Hello, it's Dr. Lewis, and I'm returning with the second half of this Word document, or this chart, where we look at Cushing's disease versus Addison's disease. Now, as we've discussed, Cushing's disease and Addison's disease are both endocrine disorders involving either hypersecretion or hyposecretion of the hormones cortisol and aldosterone. Also remember that cortisol's job in the body is to help make more glucose available during a longer term stress response. So under physiologic stress, cortisol release is going to cause an increase in blood glucose. Okay, aldosterone's job in the long-term stress response is to cause renal conservation of sodium for the purpose of blood pressure maintenance under a long-term stress response. Just to kind of circle back around to where we are. In the last video, I went down the table talking about the problems related to Cushing's disease. Now I'm going to talk about Addison's disease, and we're going to do the same thing. And so we're going to look at the patho or hormones. And the hormones are too little or not enough cortisol and aldosterone. Okay. This means this patient has a poor long-term stress response, or even a poor physiologic stress response. And this is going to come into play later. Again, electrolytes / labs. We know cortisol's job is to help with blood glucose maintenance when the body is under stress. When the body is under physiologic stress, it tends to burn more fuel. When now we've lost one of the arms of maintaining a good glucose while the body's under stress. So patients with Addison's are much more likely to have hypoglycemia. If we look at not enough aldosterone, okay, we're looking at a problem with not enough sodium. So we're going to have hyponatremia. Because of the sodium and potassium issue, okay, you're going to have hyponatremia and hyperkalemia. You also will develop a hypercalcemia. Those are the main lab abnormalities. And again, if you follow the hormone and think about what the hormone does, it may help you to reason out these lab abnormalities. Because I have a hyponatremia, and the purpose of aldosterone is blood pressure maintenance, and you're more likely to have a fluid volume deficit. Okay, because usually water follows sodium. Okay, you're going to have renal excretion of sodium. You're more likely to have a fluid volume deficit. And now you've got your signs and symptoms. And your signs and symptoms, okay, some of these are intuitive and opposite of what you're going to see in Cushing's, but not all of them. So for example, hypotension, that makes sense. Okay, we've got fluid volume deficit, we've got lower sodium levels, so hypotension makes sense. Okay, we've also got hyperpigmentation. So like a bronze skin coloring. You can see weight loss. Patients will have salt craving, makes sense. Their salt levels are low. So this is the one time you go out and tell that patient to go have some Cheetos or some Doritos or something with salt. Okay, these patients will have orthostatic hypotension. They're likely to develop weakness and fatigue. Remember, you need glucose for energy. Okay, without glucose, you're more likely to have weakness and fatigue. Okay, dizziness, nausea, anorexia. vomiting, all related to having Addison's disease. Does not sound like a real good time. Okay, dehydration. Okay, so there's a lot of different things here that are related to having not enough cortisol or aldosterone. So the good thing about having a hypofunctioning disorder, like I've said before, is that you give back what's missing. And so there's things you can give. So you're going to give glucocorticoids or corticosteroids. So somebody with Addison's is going to be taking corticosteroids. Okay, and remember, if you're recognizing a corticosteroid drug name, think about SONE or SLONE, Salone, okay, or CORT, COR. So fludrocortisone, also known as Florinef, is specifically meant for an aldosterone replacement. So you may see patients on fludrocortisone, especially if they're having a real problem with hypotension. And the idea of fludrocortisone is to promote sodium and water retention by the kidneys. So I'm just going to write promote. So helping maintain electrolytes and blood pressure. So fluid volume. We tell patients with Addison's to wear a medical alert bracelet. One of the things that can happen is if somebody has Addison's, they're going to have a very poor stress response. So if somebody is under physiologic stress, like they've had a car accident, and they have a decreased level of consciousness, a first responder is not going to know that they have Addison's until, and then they're going to have a patient who's hypotensive, who maybe has poor decreased level of consciousness. So it's very important for a patient to wear a medical alert bracelet in the case that if they're under stress, they're not able to speak for themselves. They know that the patient will need supplemental corticosteroids for treatment anytime they're under stress. If the patient is going in for a surgery, you're going to pre-treat with steroids before a stressful procedure. So those are the big things we talk about with relation to Addison's. And then we have emergent treatment because Addison or adrenal crisis that didn't go the right direction there. So Addisonian or adrenal crisis. Okay, this usually happens either if somebody is on long-term corticosteroids and they abruptly stop taking them, or it can happen because of somebody who has Addison's disease who suddenly undergoes some physiologic stress, whether that be surgery, trauma, infection. All those things are physiologic stressors, and if the patient doesn't have that aldosterone and cortisol, they may experience this profound hypotension, and hypoglycemia during physiologic stress. Okay, may be manifested by abdominal pain or headache, as well as nausea and vomiting. As far as treatment goes, again, we're going to give back what's missing. Okay, so treatment is corticosteroids. But if someone doesn't know that, and I had a paramedic student one time who says, you're trying to stabilize the patient. If the patient is hypotensive, you stabilize them with isotonic fluids. I wrote treatment. But this patient was a trauma patient who had a very low blood pressure, very low glucose, and they were trying to stabilize the patient. And as it turns out, the patient had Addisons and they didn't know it. And as soon as they gave the patient corticosteroids, IV corticosteroids, they started seeing improvement in the patient's vital signs. And so that was kind of my lesson for that, it's important for patients to be able to communicate that to people. So this concludes my session on Addison's disease. If you have any further questions, please reach out to me. Thanks a lot for your time and attention.